Parenting podcasts can be a bit earnest. Parenting Out Loud is not that podcast.
This person who I may not agree with politically is trying to talk about integrating children, not just into his professional life, but into public life.
I have referred to myself as one and done. That article did make me rethink the term.
It took about 11 seconds for this to go viral.
Oh God, is this the ejaculate one? That is deranged and I love it.
Parenting changes the way you see everything. Parenting Out Loud takes the big conversations of the moment and puts them through that filter.
Because if parents are thinking about it, we're talking about it.
Parenting Out Loud. Listen weekly wherever you get your podcasts.
You're listening to a Mamma Mia podcast.
Essentially, male doctors invented vibrators to treat hysteria to induce what they referred to back then as a hysterical paroxysm, what we would today probably refer to as just having an orgasm, right? Now, if you think about it back in Victorian times, we don't know how often women were achieving orgasm in day-to-day. Like, maybe never. And maybe she wasn't even given the opportunity or taught how to do it on her own either. Yeah. So she may have never done that. So, she gets hysteria, gets treated. Bob's your uncle. She feels very relaxed after that. Hello, welcome to Well Australian Women. This is your full body health check. I'm Claire Murphy, and in light of today's conversation being about breast cancer, just want to give a shout out to my mum. She was diagnosed with a breast cancer, I think it was late last year, and she handled it like an absolute pro for a woman who has like severe medical anxiety. She got in there, got it chopped out and got on with it, and good on you, mum.
Good on you, Mum. And I'm Dr. Mariam, and as a GP, I am supporting patients at every stage of their breast cancer journey. So from that initial discovery of the lump, through the anxiety of awaiting biopsy results, to delivering both hopeful and sometimes challenging news. I've been walking alongside them during treatment and beyond. And many of my patients also have loved ones affected by breast cancer. So I understand the ripple effect this disease has on families and communities.
I never considered how much news you have to deliver to people all the time. That's a lot.
Yeah, you have to prepare for it. That's a consultation. It's hard.
Imagine your stress levels increase too when you know you have to deliver that kind of news.
It's a lot. It's something we carry with us, not just for that consultation, but definitely beyond.
Yeah. Well, later we are going to be catching up with oncologist Dr. Belinda Yeo to talk through issues around breast cancer, from gene screening to lump detection, treatment, and the latest research, including one I'm presuming a lot of others have been seeing on their Instagram feeds, and that is the use of bee venom to treat breast cancer. So we'll ask her about that as well. In today's quick consult, Tara is super annoyed that a skin condition that she suffers from has migrated. And as someone who also deals with this, I'm very keen to know what your answer to her will be today, Dr. Mariam.
This time it's up, not down.
Yeah, it is not on her vagina. Next, though, Mariam, did you know that men accidentally invented vibrators for medical purposes?
Why is it no surprise Amel is behind this?
Shouldn't be. A med school history lesson up next.
Welcome to med school.
Now, Mariam, you know that I'm a history nerd.
I love these segments. I love them.
And sometimes they're accompanied by really fun pictures, and there will be one for this one too.
Epic.
Did you know that male doctors in the 1800s treated women with this fabulous affliction that was referred to back then as hysteria?
Tell me more.
Now, let's be clear. We do not diagnose women with hysteria anymore, but it covered a whole bunch of things, including actual mental health issues. But it also included her like showing any form of emotion or disagreeing with men or being dissatisfied with her role in life. She's obviously hysterical and needs to be medically treated for that. It was basically any behaviour that didn't sort of fit the ideal of that submissive Victorian lady. Well, doctors in the 1800s believed one course of treatment for said hysteria was genital stimulation.
Oh, that's one way to get rid of it.
Yeah, well, I can see where they were coming from, because although they knew that that was potentially a treatment, they didn't want to tire their poor fingers out having to do that. So they invented machines to do it for them. Get a gander at this guy. So this one is steam-powered. How fun. We'll put this one up on our socials so you can see it too.
It's too good.
on Instagram, we are Well by Mamma Mia. Essentially, male doctors invented vibrators to treat hysteria to induce what they referred to back then as a hysterical paroxysm, what we would today probably refer to as just having an orgasm, right? Now, if you think about it back in Victorian times, we don't know how often women were achieving orgasm in day-to-day. Like, maybe never. And maybe she wasn't even given the opportunity or taught how to do it on her own either. Yeah. So she may have never done that. So like she gets hysteria, gets treated. Bob's your uncle. She feels very relaxed after that. Like what a surprise. Imagine how many women are like, I have hysteria.
I love this. Can you believe the humble vibrator started out as a Victorian era invention just to save doctors' fingers from fatigue? I know.
Like if men were just committed a little bit more to using their hands, we may never have got vibrators.
The picture that you've showed is actually called the manipulator.
Is it?
That's what it's called. That's what it's called. I love it.
I don't know the inner workings of the manipulator,
but work up the manipulator.
Go on our socials and have a look. And thank you, men, even if you kind of did it accidentally. We appreciate the invention.
Finger fatigue.
Finger fatigue. You avoided it and gave us a little bonus in the interim. All right, shall we get into today's checkup? We are talking about breast cancer today.
It's time for the checkup.
It has cricket stadiums awash in pink. It has its very own ribbon. There have been millions and millions of dollars raised for this cause, which has translated to real world impact. Of course, we are talking about essentially what has become the rock star of women's cancer, and that is breast cancer. It's actually quite amazing how much having the spotlight on breast cancer has changed the research and the outcomes of this particular cancer. So the death rate from breast cancer has been slashed by over 40% since the 90s when we really started to shine a light on it. And the 5-year survival rate has jumped from 78 to 92%.
Amazing.
In that time frame. In fact, Australia has one of the best breast cancer survival rates globally, which is incredible. And we can put that down to basically getting some really good PR and a ton of money to go into research to help look into it. It is the most common cancer diagnosed in women in Australia. Of course, it does also impact trans men and some men as well, although in lower numbers. My mum, as I mentioned earlier, was diagnosed with a ductal carcinoma. She has made a full recovery from it. In fact, she showed me her boob the other day, and this is wild. So he took out she explained it like a slice of pie.
Yeah.
So they cut out like a wedge and then have to sew it all back together. And if you could not see this tiny weeny little scar, you would not even know that she'd had a little chunk removed. Yeah. So the ability for surgeons to cut these out and actually do amazing reconstructive work or just make it look minimally invasive in the end is quite great. How many women would you say you see coming into your rooms after finding a suspect lump, for example, and after we do our monthly checks?
I see at least a few every week. So I'm doing breast exams maybe 5 to 10 times a week for suspected lumps. And it should be a monthly habit. It's really important to be breast self-aware. So we really want people knowing their boobs really well. So my general advice is if you're still menstruating, pick a few days after your period ends and just get to know your boobs really well. Do those examinations because we know when you pick up something, that early screening can really, really save lives.
Yeah, and just for those who aren't aware, everyone's boobs feel different.
Yeah, that's right.
And so like yours to mine would feel different, and it really is just whatever your normal is, right? Because some women, the milk ducts are more prevalent and you can feel them more, or some people might have more dense breasts or more fatty tissue in there. So everyone's feels slightly different. It's just whatever is normal to you, whatever starts to not be normal, that's when you go get it checked out.
And that's right. When you have this monthly relationship with those examinations, you'll be like, oh, I don't think that was there. And I didn't feel that there last month. And that should set the alarm bells.
Plus, you also know, like when you are going through hormonal changes, it might be mine get a little bit firmer and they get a little bit painful. So like you know that that's normal for you, right?
That's right. That's why we always say if you do these breast checks at home, that you do it after your period. And if you are postmenopausal, just pick a random day of the month and just stick to those monthly checks if you can.
Give it a little feel up.
Yeah. It's all about being breast aware.
Also, touching your boobs is kind of fun.
It is.
I mean, that's what my husband says. All right, we are going to be getting into this in a little bit more detail with Dr. Yeo when we speak to her. We do have a quick consult on the way too for Tara, who's not happy about her skin condition spreading. But we are going to get into boobs in a little bit more detail next, including knowing how dense your breasts are. That is really important. Joining us today to get the lowdown and latest on breast cancer is Dr. Belinda Yeo. She's a medical oncologist and a clinician scientist at the Austin in Melbourne and the Olivia Newton-John Cancer Research Institute. May Olivia rest in peace. What a wonderful human being. And we started our chat with Dr. Yeo asking about our main risks for developing breast cancer. We wanted to kick off with something I think a lot of women are concerned about, and that is the question about whether our genes are the main risk factor when it comes to developing breast cancer. How important is our family history here?
To be honest with you, family history is not the most important thing for the vast majority of patients who get breast cancer. The most common risk factors for developing breast cancer being female and getting older, and unfortunately those two things we generally can't change. Genetic breast cancer, so I guess what we mean by that is being born with a gene or being the first to develop that gene that puts someone at a particularly increased risk of breast cancer is actually pretty uncommon. So that only makes up about 5, maybe somewhere a little bit closer to 10, but mostly about 5% of breast cancer we see. So I guess the take-home message there is that the vast majority of breast cancer that we see is not in fact genetic.
Are there different types of breast cancer though, Belinda?
Yeah, so the most common type of breast cancer is the one that's driven by our hormones, and the most important hormone here is estrogen. And it doesn't seem to matter how much estrogen you have. So that's why postmenopausal women often get breast cancer that's driven by estrogen. So I say this to patients all the time. It doesn't really matter how much is there. It's what your body seems to do with it. So that makes up about 80% of breast cancer. And so the more uncommon forms of breast cancer are the breast cancers that are not predominantly driven or grown because of the hormone estrogen. And that is either a breast cancer called triple negative breast cancer. So that's defined by what it isn't. It's not driven by 2 of the main hormones, and it's also not driven by a protein called HER2 or HER2. And that's about 10% of breast cancer. The other amount of breast cancer is made up by that protein called HER2, so HER2. And this is a protein that's ramped up or drives, I say about 1 in 6 breast cancers. It might even be a little bit less than that. And fortunately, whilst those breast cancers are quite aggressive, we've got very good treatments against the HER2 positive breast cancers that make a massive difference.
Now, there's obviously been quite a wide public campaign about women regularly checking their breasts, and the Cancer Council has modified that slightly to not necessarily checking in once a month, but just becoming breast aware and what your normal is. But how do we know when a lump is actually a lump? Is it always obvious?
Absolutely not. And, I guess I'm biased, right, because I'm a medical oncologist. So the lumps I see are always breast cancer. But particularly in young women, most lumps are fortunately not breast cancer. I always say to people, it's not your job to work out if this is a cancer or not. I think if you feel something that you're worried about, then that's when you go and seek attention. And yes, it's very good to know what your breasts feel like and to be breast aware. And our breasts change. If you're premenopausal, they change across the cycle. And even for some postmenopausal women, our breasts change. So I think it's about, knowing what your breasts feel like so that if something's abnormal, if something comes up, then that's when to seek attention. And of course, screening, so going and attending and getting your breast imaged when you don't have any symptoms is what we rely on to be able to detect things before anyone can feel a lump. So screening is for patients who cannot feel or don't have any symptoms. Really important. If you actually feel a lump, then you should seek medical attention for it, and we go from there.
Can we talk about screening and breast density? It's been in the news quite a bit lately in that if you have very dense breasts, screening might not necessarily be as accurate for you. Is that right?
Having dense breasts is indeed a risk factor for developing breast cancer, but we've known about breast density for a really long time. And I think what we hopefully will see in the coming years is that our screening programs will start to be tailored towards things like breast density. So at the moment, our screening program is really one size fits all. Everybody turns up at a certain age and we screen people for 20, 25 years. But I think as you'll see, it's a hard thing to change, but I think we'll start to see tailored programs where patients with more dense breasts might be offered a different type of screening. And the flip side of that is patients with really very little breast density might be offered something less. So it is a risk factor. But I guess I should say that it doesn't mean that screening is a waste of time. I don't think that's a very good take-home message. Patients with dense breasts do still need to undergo screening.
There is a lot of fear-mongering happening right now on social media where it does come to breast screening, though, and there's a lot of people who are saying that mammograms actually cause breast cancer, that the radiation that is happening when you have a screen is actually the thing that will cause a breast cancer. Is there any truth to that?
There's no truth to that. I understand people's fear. I mean, the word radiation doesn't sound fantastic, but there's radiation when you jump in a plane and go on a flight interstate or certainly internationally, and none of us really think much about that. So my only message here is to say that the radiation associated with having a mammogram is really minimal and has not been shown to increase your risk of breast cancer.
Can I ask you about the breast cancer lifetime risk assessment test? This is something that actress Olivia Munn has been talking about, and she's credited that as saving both her and her mum's life. Is that something that we look at here in Australia?
There are assessments that you can go on and do yourself online, and some of these are actually really detailed. So they go through and you enter your details, and then it asks you about your first-degree relatives and then second-degree relatives and other risk factors. Do you know your breast density? Yes or no? What is your age? What is your menopausal status? And some of these are absolutely validated to help give what is your risk of breast cancer as opposed to the population risk. So, for example, in Australia, we say that over your lifetime, 1 in 7 women will develop breast cancer. We have one of the highest rates of breast cancer in the world, sadly. But these can be modified for the individual patient. So if you're interested in doing that, yes, you can certainly go online.
Why do you think our breast cancer rate is so high here in Australia? Is there something in the Aussie lifestyle that's contributing?
I wish I knew the answer to that, obviously. We have a lot of things that increase your risk of breast cancer, but at a very small rate. Your biggest risk factor is being female and getting older, but then there are other things that play a part. So obesity plays a part, particularly in postmenopausal breast cancer. So the age a woman gets her first period, and certainly when she goes through menopause, so that's a risk factor. Not having children is a risk factor. Smoking, alcohol consumption, these types of things are risk factors. And obviously family history, and whether or not there are in fact those rare genetic findings in families are risk factors. So all of these do add, but exactly how much they add to the individual patient, I have to say the vast majority of patients that I look after, they say, why did I get this? And I never have a very good answer for them. I mean, we definitely go looking for breast cancer. When you screen a population, then you'll find more breast cancer because you're actively looking. And if you look at the historical data for breast cancer in Australia, when we started screening patients, then obviously we were finding more, so the incidence of breast cancer went up. But screening definitely doesn't explain everything. There are carcinogens in our environment. I think it's very difficult to detail how much these all add, but I suspect these are all just gradually increasing that risk. So there's no easy answer to that.
Are there any links between breast implants and breast cancer?
No, but I think the one that scares people is that with certain implants that have been more historically used than are currently used, these are textured implants, there is an association, and it's an extremely rare association with a certain type of cancer. And I guess what I would absolutely not want to do is send a panic out to anyone who's got a textured implant, because these are extremely rare outcomes.
Does diagnosis always mean chemo and or surgery? I mean, I know some people get a full mastectomy, some people have chemo treatments, and then there's other people like Olivia Munn, who we mentioned, she had endocrine therapy, and then there's those you talk about are fed by estrogen, and so they can't take anything with hormones. What does treatment look like nowadays?
Treatment's more and more complicated, but treatment is more and more tailored to every individual patient. So each patient will have, honestly, quite a different story to the next patient you see. So I guess the first thing to say is getting the diagnosis and knowing the type of breast cancer, which we talked about before, that's really important. And then knowing the extent of the breast cancer, how much cancer is actually there, and we do that based on our imaging. And then the question is this breast cancer is localized to the breast and the lymph nodes? Mostly surgery is used, but drug treatment can be used before surgery to try and shrink the cancer down. And that's actually becoming more and more common around the world to try and get a sense of whether the drugs are working. But surgery is very common and almost always used when we're aiming for curative intent in breast cancer. And the extent of surgery, there's two things to consider. How much surgery to the breast? So is it removing the cancer and the region around it. That's called a lumpectomy or breast conservation versus removing the breast in its entirety, and that's obviously a mastectomy. Then there's the issue of the draining lymph nodes. So these are the lymph nodes under your arm, and we do almost always assess those to see whether the cancer's spread to them, because that's a risk factor for the cancer also going elsewhere. And so the next question for the surgeon is, well, what kind of surgery is needed under the arm to work out if those lymph nodes are involved? So that's surgery. Other local therapies are things like radiotherapy. So that's trying to sterilize where the cancer started to stop it coming back there. And then I'm a medical oncologist. So what I do, I give the drugs. So chemotherapy is kind of, I guess, the elephant in the room. Everyone knows about chemotherapy. And I'm glad to say actually that many patients who have breast cancer actually do not need chemotherapy. Most patients who have those estrogen-driven cancers, the ones driven by the hormones, they're the ones who need the tablet therapy to try and stop or block estrogen. And there's different ways we do that, and it depends on what kind of risk factors are there. So that's very common. In breast cancer, if estrogen is an important driver to the cancer, we do exactly the opposite. We try and block or hide estrogen from the breast cells so they can't see it. And then there are many other targeted therapies we use. Even immunotherapy, I'm pleased to say, is now part of some of the breast cancer that we treat, not the majority, but certainly some. And we're getting cleverer and cleverer drugs all the time.
Can I ask you just finally about a couple of research studies that have been popping up on my social media feed that seem quite out there, but I want to know if you've heard about them too. The first one was a study from the Harry Perkins Institute of Medical Research over in Perth, and they've been using honeybee venom to kill breast cancer cells. That's been doing the rounds. And the other one was out of Germany, where scientists discovered that some peptides found in the mucus of axolotls, who I hear are not mistreated. They gently stroke it and get the slime off them to use this. They've also been used in breast cancer treatment. Are these things like wild theories, or are these things that we're actually close to discovering breakthroughs with, you think?
Look, it's really hard. I don't know about the German one. Certainly I've looked into the honeybee study in Perth. These things make great headlines, and sometimes that's because they really are novel ways to be trying to treat cancer cells. And the first thing I always look to see is the research done in the lab? So is it done kind of with cells in a dish, and whatever the therapy is, be it the honeybee or being tested on those cells? And that's usually the first place we start in trying to test novel therapies. Does this kill cancer cells in a dish? And if it does, and oftentimes that's the thing that we see, first on social media or on the news, look at this new treatment. But what's really key is when we find those really early signals, that is quite a long way to taking it down to the clinic and saying, can this kill the cancer cells in our patients? Because obviously, we're human beings, and everything in us behaves differently to how it does in a petri dish. So I don't want to squash any of those ideas. I mean, I think any novel ways to be able to improve our therapies, improve outcomes for breast cancer, but also cancer as a whole, are extremely important. And, I believe in this. But I think you always have to have that little bit of equipoise. All right, well, where is this? In fact, I just got from a patient, should I be using the honeybee stuff? And I think you just have to be careful. You want people to have hope, absolutely. But unfortunately, these findings often take many, many years to then reach our clinic and indeed reach our patients.
A big thank you to Dr. Yeo. Have you seen these new breast cancer screening machines? They've been popping up on my feed quite a bit lately, where instead of standing up and pancaking your boob in, you lay down and kind of pop your boob in a hole.
They're called Cone Beam Breast CT,
right?
CBBCT.
Okay.
And the tech is officially here in Australia, which is massive because it offers a far kinder alternative to those classic pancake mammograms. So you pretty much lie face down. So one breast goes through this opening while the scanner gently circles, and you get a fast 3D image, no crushing, and it's usually done in about 7 seconds per breast. So quite fast.
So fast.
The only issue is it's not widespread yet. It may take a bit of detective work to find a location near you. Most centres are yet to adopt it. That's why it's a good idea to first have a chat with your GP. They'll refer you and guide you towards any waitlists or private clinics offering it and help you weigh costs and whether it suits your needs.
I've had a couple of mammograms now. It's not the most comfortable experience. It wasn't painful or anything.
Yeah.
It's just kind of you stand in some weird, awkward stances with the arms above your head. And a nurse who is touching 1 million boobs a day is manipulating it into this little slide so it can squish it down a bit. I know some of my friends struggle a bit because they get a bit of boob pain from it, but your experience will be different depending on what your boobs are like.
That's true. I've got patients with smaller breasts or larger breasts that find it very painful. It's very, very patient dependent,
Yeah.
but it is an option for those who really struggle with the
Also,
mammograms.
I'd love to see what my boob looked like just face down through the hole in the table. Like, I had a baby who's like basically changed them from boobs to like, I don't even know what you call them now. They're fairly flat, but like hanging through theirs is going to be a little sad. A little sad boob out the bottom. But it's worth checking out if that's something you're worried about, then, you know,
definitely
might be an option for you. Okay, next, it is quick consult time. Tara is pissed, to say the least. Her skin condition is spreading and she wants to know what to do. Are we ready to get our quick consult on today, Marion?
We sure are.
All right, do your thing.
The doctor will see you now, just through here to consult room 1.
Thanks for waiting. How can I help you?
Heads up, if you do want to ask Dr. Mariam a question, she loves it. You can get questions to her a few ways. Chat to us in the DMs. You can hit us up on email, which is well@mamamia.com.au. If you prefer, pop into the waiting room because you can be anonymous there. But, I mean, we can make you anonymous regardless of how you contact us. In the show notes, you will find a link to the waiting room. Okie dokie. Tara has something I can sympathise with. She wrote in asking this.
I have had eczema all of my life, mainly on my legs and arms, but I've never had eczema on my face before. Suddenly, I now have it in my nasolabial folds. I'm 37 years old. WTF.
Now, I had to look up what your nasolabial folds are. They're those skin creases that run from like the bottom of your nose to the edge of your mouth. Makes it look like that area is kind of in brackets.
Yeah.
So she's getting it quite a bit in there. And Tara, as someone who got it on one nipple for a while, it can pop up in weird spots, right?
Yeah, it can. So it can feel confusing if it's just come out of the blue, but it's actually more common than you think. So let's dig into what could be going on. So seborrheic dermatitis is actually the most likely culprit. It tends to pop up in oily, creased areas.
So it may not be eczema?
So it's a type of eczema.
Oh, a type of eczema.
Yeah. And it comes up in those folds, like the nasolabial folds, can also pop up on the side of the nose and eyebrows. Often it's red, you've got flaky patches. It's usually a reaction to yeast living on your skin. It's not alarming, but manageable once we know what's up. Another possibility is something called perioral dermatitis. This rash usually shows up as tiny red bumps around the mouth or the nose, and sometimes even near the eyes. It's often triggered by things like steroid creams, surprisingly, sometimes facial products or even toothpaste or nasal sprays. The products can throw the skin's balance off and can lead to this rash. Then we have something called contact dermatitis. There's so many different types, which essentially is irritation from something touching your skin. So if you've started a new makeup or cosmetics, skincare.
Someone mentioned to me, because I was getting a flare-up for no good reason, but we'd changed our laundry detergent.
Yeah, that's a massive one.
Yep.
And that can look and feel a lot like eczema as well. So what can you do right now? I would advise to take a break from any new or heavy products, especially creams or cosmetics that you might be using near your upper lip or nose. Keep it simple. Less is more with skincare. So switch to a bland, fragrance-free moisturizer and gentle soap substitutes. Think of it as a mini reset for your skin. And if the rash sticks around, worsens, or it started after using a steroid cream, I'd really pop in to see the GP. Getting an accurate diagnosis will help guide the management just to make sure it is actually eczema and not something else.
Can you get steroid cream over the counter?
You can, but for the face, I always recommend seeing a doctor because we don't like using steroids long-term on the face, and it depends on the region as well.
Yep.
There are also non-steroid alternatives as well.
Okay, good to know. Well, hopefully that did clear this up and will clear up that rash for you too. Thank you so much, and thank you for spending some time with me and the good doctor today. Remember, advice that you hear from Dr. Mariam, whilst it is wonderful, is not specific to you. So you need to go and take that to your doctors or your healthcare professional team, because sometimes it's more than one doctor. Next week, we are getting into all of your questions around the various cancers that we've been talking about. So we're looking at breast cancer, as we've spoken about today, but bowel cancer as well as ovarian and cervical, all of those. So if you do want to get your questions in, link in the show notes, make sure you let us know about them. And have a tops day. Catch you for your appointment next week.
Bye-bye.
Well is produced by me, Claire Murphy, and our senior producer, Sally Best, with audio production by Scott Stronach, video production by Julian Rosario, and social production by Ellie Moore.
Mamma Mia acknowledges the traditional owners of the land we have recorded this podcast on, the Gadigal people of the Eora Nation. We pay our respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander cultures.